Disclaimer: I do not own the rights to the information provided. It was purely made for the purpose of board study. Prep cerebrospinal fluid, CSF, is a clear, colorless fluid that surrounds and permeates the entire central nervous system, CNS, and therefore protects, supports, and nourishes it. In general, CSF is produced within the ventricles of the brain by the choroid plexuses, circulates to the subarachnoid space, and is absorbed into the venous sinuses. Production CSF originates from capillaries throughout the CNS and leptomeninges. A major site is the choroid plexus located in the lateral, third, and fourth ventricles. Small amounts enter the ventricles from the parenchyma through their ependymal lining and enter the subarachnoid space through the pyoglial membrane on the external surface of the parenchyma. Capillaries within the parenchyma are small source via microscopic interstitial spaces. Leptomeningeal capillaries in the subarachnoid space are an additional small source of CSF. Studies of CSF production determined that 35% was derived from the third and lateral ventricles, 23% from the fourth ventricle, and 42% from the subarachnoid space. The choroid plexus consists of numerous fronds of villus processes that project into the CSF of the ventricular system. The simple cuboidal cells of the plexus are continuous with the ependymal cells that line the ventricular surface adjacent to the CNS parenchyma. Figure 4-1. At the choroid plexus, essentially two cell layers exist between blood plasma and ventricular CSF and between the vessel endothelium and the choroid plexus, ependymal, epithelium. The vascular endothelium is separated from the choroidal epithelial cells by a thin basement membrane and loosely arranged meningeal cells. The endothelial cells of the choroid plexus capillaries are considered to be fenestrated because they lack tight junctions. This is different from the capillary structure within the parenchyma. The epithelial cells of the choroid plexus are robust cuboidal cells with tight junctions at their ventricular, apical, surfaces. They have the characteristics of cells that function in the transcellular transport of materials. This includes microvilli on their luminal surface and enfoldings of the basal portion of the cell membrane. This is a semi-permeable barrier that selectively and actively transports some substances and inhibits others. The methods of CSF production are a selective ultrafiltrate from blood plasma and active transport mechanisms that utilize energy. Compared with blood plasma, CSF has less potassium and calcium and more chloride, sodium, and magnesium. It has less glucose, about 80% of that in blood, and much less protein. Plasma protein is measured in grams per deciliter, GDL, whereas CSF protein is measured in milligrams per deciliter, mgdl. In the dog, the normal total protein level does not exceed 25 to 30 mgdl, and it is predominantly composed of albumin, bile salts, products of hemoglobin breakdown, and many pharmaceuticals, including penicillin, are prevented from entering CSF from blood. The rate of production of CSF varies with the species and the method of determination but is remarkably rapid. The total volume of CSF is produced and absorbed about 3 to 5 times per day. The following rates have been determined. Dog, 0.047 milliliters per minute ml min. Cat, 0.017 ml min. With this continuous turnover of CSF, evidence suggests that it is produced at a constant flow rate, regardless of increases or decreases in CSF pressure in the ventricular system. In chronic obstructive hydrocephalus, atrophy of the choroid plexus decreases CSF production. The rate of CSF production is independent of the hydrostatic pressure of the blood but is influenced by the osmotic pressure of blood. Intravenous administration of hypertonic solutions reduces the rate of formation of CSF. This has clinical application in head injuries involving brain edema and a neurosurgery performed for space-occupying lesions. An osmotic diuretic is administered to decrease the rate of CSF formation and to decrease the vasogenic edema associated with the brain lesion. Brain volume will be reduced and intracranial pressure, ICP, will be lowered. The most common osmotic agent used is mannitol, a hypertonic solution of a carbohydrate. It is administered intravenously at 0.25 to 2 grams per kilogram of a 20% solution. If mannitol is administered intraoperatively, the reduction in the size of the brain is grossly visible. As can be imagined, this may be clinically important if the brain begins to herniate at the craniectomy site. An alternative to mannitol is hypertonic saline. Hypertonic saline, 7.5% sodium chloride, is typically administered at 4 ml/kg. Meninges, subarachnoid space. Before we consider the circulation of CSF, it is worthwhile to review the anatomy of the meninges. It must be kept in mind that the entire CNS is covered by 3 layers of connective tissue. Figure 4-2. These layers are derived predominantly from the neural crest with a small component from the mesoderm. The most external layer is the thick, fibrous dura mater, which, within the cranial cavity and portions of the first 2 cervical vertebrae, closely adheres to the bones of the skull and vertebrae. Within the remainder of the vertebral canal, the dura is separated from the vertebrae by the epidural space, which often contains fat. The arachnoid membrane is a thin layer of connective tissue that, in life, adheres to the dura by means of dysmosmal attachments. Figure 4-3. No subdural space exists in the normal living animal. Contrary to what is reported in the literature, it is a potential space that may develop under certain pathologic circumstances. These neurarachnoid dysmosmal attachments are easily disrupted by hemorrhage following an injury, subdural hematoma, by contrast agents inadvertently injected into the dura arachnoid, and following death, when CSF pressure is lost. It should be noted here that subdural hematomas are rare in veterinary medicine compared with their occurrence in humans. This arachnoid membrane is the external surface of the subarachnoid space, which contains CSF, blood vessels, spinal nerve roots, and arachnoid trabeculations. The latter thin, collagenous extensions from the arachnoid membrane to the pia mater, which is the thin layer of connective tissue attached to the surface of the CNS parenchyma, where it forms a pyoglial membrane. The thick dura mater is also called the pachymeninx, and the thin vascularized pia and arachnoid make up the leptomeninges. Circulation. CSF circulates from the ventricular system to the subarachnoid space by way of the lateral apertures of the fourth ventricle. Figure 4-4. In some animals, a similar passage exists between the central canal and the subarachnoid space at the conus medullaris. See Figure 4-2. Primates also have a median plane aperture, the foramen of Magendie, in the caudal part of the roof plate of the fourth ventricle. Much of CSF passes dorsally over the cerebellum, ventral to the tentorium, and then over the cerebrum where it has access to the venous sinuses. CSF covers the entire external surface of the brain and spinal cord, where it can penetrate the parenchyma along with the larger blood vessels in their paravascular spaces. These spaces are extensions of the subarachnoid space to the point where the pia mater blends with the adventitia of the blood vessel. This is not a distinct point, and for some distance, the cells of the leptomeninges in the adventitia of the blood vessel may be closely related in the paravascular space reduced to small clefts between cells. Ultimately, CSF has access to the very small interstitial spaces of the CNS parenchyma. Altered CSF flow patterns along the spinal cord subarachnoid space led to syrinx formation. These flow pattern alterations may also contribution to the formation of a subarachnoid diverticulum. These diverticula are incorrectly referred to as subarachnoid cysts in the literature. The flow of CSF in the ventricles is thought to be caused primarily by the pulsations of blood in the choroid plexuses as well as the activity of the modal cilia on the exposed surface of the ependymal cells. Remember that the cranial cavity is a closed space consisting of 3 components: 1. Brain parenchyma, 2. Blood, and 3. CSF. Figure 4-5. Any increase in the volume of one of these compartments must be compensated for by a reduction in the volume of another compartment. With each arterial pulsation, CSF pressure rises and surges toward the lateral apertures. Movement of CSF within the subarachnoid space of the cranial cavity and from the cranial cavity to the spinal cord subarachnoid space is also dependent on cardiac systole and intracranial arterial pulsations in the closed space. Interference with this flow at the foramen magnum may lead to the development of a syringohydromelia, as discussed in the section about brain malformations in Chapter 3. The effect of this arterial pulsation on CSF movement is remarkable when viewed using phase contrast magnetic resonance imaging, MRI, sequences to view CSF flow. See video 4-1. In addition, during surgery that involves the ventricular system or the subarachnoid space, the surgeon can directly view the arterial pulsatile effects on CSF flow. In relationship to cardiac systole and diastole, CSF may move cranially and caudally, but the caudal flow predominates. Radioiodinated serum albumin injected into the lumbar cistern of humans may be followed by scanning radiographic procedures to the dorsum of the cerebrum in 12 to 24 hours. Similar injections into the lateral ventricle appear in the thoracolumbar subarachnoid space in 30 to 40 minutes, reflecting the predominant caudal flow of CSF. 7. Comparison of cerebellomedullary and lumbosacral CSF in animals with focal spinal cord disease supports the predominance of the caudal flow of CSF. The sensitivity of the close relationship among the 3 compartments of the closed cranial cavity as well as a demonstration of the continuity of the intracranial and intra-vertebral subarachnoid spaces is seen when CSF pressure is monitored at the cerebellomedullary cistern and when the external jugular veins are compressed. This extracranial venous compression causes an immediate increase in intracranial blood volume, which requires more space. CSF volume is compressed and displaced through the foramen magnum, causing an elevation in the pressure in the spinal cord subarachnoid space, which can be seen in the pressure measuring manometer. For a similar reason, the CSF in the manometer will rise and fall in synchrony with respirations, reflecting the associated changes in thoracic venous pressure. If a pressure measuring manometer is also placed in the lumbosacral subarachnoid space, the same observations will be made because of the continuity of this space for the full length of the spinal cord. If the continuity of the CSF-filled space is compromised by a space-occupying lesion such as a neoplasm or an abscess along the spinal cord, CSF pressure measured at the lumbosacral subarachnoid space will not be elevated when the external jugular veins are compressed. In humans, this is called the Queckenstedt, or jugular compression, maneuver. Other practical applications of the knowledge that the cranial cavity is a closed space relate to intracranial injury and neurosurgery. When an animal is positioned for intracranial or cervical spinal cord surgery, the head and neck should be elevated and suspended by a specialized holding device rather than placed on a padded surface so as to avoid compressing the external jugular veins. A practical test to ensure the avoidance of external jugular vein compression is that the surgeon can freely pass his or her hand between the surgical table and the ventral surface of the patient's neck. When an animal is presented following head injury, a cardinal rule in any emergency room is to ensure that the patient has a patent airway. This not only ensures the proper oxygenation of blood for tissues but also prevents dilation of cerebral blood vessels, which would contribute to any increase in ICP. Hypercapnia causes cerebral arterial vasodilation and increases the volume of intracranial blood. If head injury has occurred, hypercapnia will augment any hemorrhage and vasogenic edema that is already present and will compromise the space available in the cranial cavity. Hyperventilation will reduce this effect by increasing oxygen and decreasing carbon dioxide in blood. This is a procedure that may be used during intracranial surgery. Some of the gas anesthetics may induce intracranial vasodilation, which makes careful selection of anesthetics for intracranial surgery important. When the intracranial space is compromised by developing lesions, the CNS is able to accommodate for it by physiologic mechanisms that are referred to as autoregulation. The purpose of this autoregulation is to attempt to maintain adequate cerebral perfusion in the presence of increased intracranial pressure, ICP, caused by a lesion. This perfusion is largely independent of systemic blood pressure. Cerebral perfusion pressure is defined as the mean arterial blood pressure minus ICP. It determines the oxygen and nutritional supply to the parenchyma. This autoregulation involves complex regulation of intracranial blood flow by chemical, neurogenic, and myogenic means to ensure a constant supply of oxygen and nutrition. It is most effective with slow-growing space-occupying lesions. Neoplasms that developed within the prosencephalon or even with extraparenchymal lesions along the brainstem can be remarkably large, without producing neurologic signs as long as growth is slow. Slow-growing extraparenchymal lesions may cause more than a 50% compression of the diameter of the spinal cord before clinical signs are seen. CNS vascular autoregulation is the basis for the preservation of the parenchymal perfusion to these compromised tissues. Clinical signs occur when the tissue demands exceed the capability of this autoregulation. Vasogenic and cytotoxic edema follow. When this occurs within the cranial cavity, the uncontrolled increase in intracranial volume and ICP forces displacements of various components of the brain that are referred to as herniations. 3 of these herniations are regularly seen in domestic animals. The subfalcine herniation is a medial displacement of one cerebral hemisphere ventral to the falx cerebri. On CT and MRI, a A sign commonly seen is referred to as a midline shift. It represents an enlargement of one cerebral hemisphere, figures 4-6 and 4-7. When the enlargement is severe, a subfalcine herniation may occur. A portion of the enlarging cerebral hemisphere that is herniated is called the cingulate gyrus. The transtentorial herniation is the displacement of the caudal aspect of one or both cerebral hemispheres ventral to the tentorium cerebelli. This directly compresses the mesencephalon and indirectly the rostral cerebellum. It can be seen on MRI but is recognized at necropsy by the marked oblique indentation in the quadrimedial aspect of the occipital lobes and often includes the parahippocampal gyrus on the medial aspect of the cerebral hemisphere, figures 4-8 and 4-9. In my, e.g., clinical experience with this type of herniation, initially patients often develop a constricted pupil followed by a widely dilated unresponsive pupil ipsilateral to the herniation, altered mentation, and gait deficits. The progressive increase in pressure initially causes pupillary constriction possibly because of disinhibition of oculomotor parasympathetic neurons from loss of the influence of prosencephalic upper motor neurons, whereas the subsequent pupillary dilation represents loss of function of these oculomotor neurons. Herniation of the quadventral aspect of the cerebellar vermis is commonly called cerebellar coning. This involves primarily the pyramis and uvula lobules, which compress the ventrally situated medulla. It may sometimes be seen on axial, transverse, MRI but is best seen on median plane MRI, figures 4-10 and 4-11. It should not be referred to as tonsillar herniation because these paramedian lobules do not herniate in domestic animals, only in primates. Absorption. The major site of CSF absorption is at the arachnoid villi that are located in the venous sinuses or cerebral veins. Collections of these arachnoid villi are known as arachnoid granulations. Occasionally, they may be seen in some species on gross examination of the lumen of a large intracranial venous sinus. The arachnoid villus is a prolongation of the arachnoid membrane and subarachnoid space into the lumen of the venous sinus covered by the endothelium of the vessel wall. See figure 4-5. Usually, the portion of the villus within the lumen is reduced to a single endothelial cell between the CSF of the subarachnoid space and the lumen of the sinus. It is structured to act as a one-way valve that permits CSF to flow into the lumen of the sinus when CSF pressure exceeds venous pressure. When intravenous pressure exceeds CSF pressure, these villi collapse, closing the valve so that no blood can pass into the subarachnoid space. Flow is one way at these sinuses, only from CSF into blood. Electron microscope studies of these endothelial cells that line the arachnoid villi have revealed transient transcellular channels that develop for the passage of materials from CSF into the venous system. These apparently develop in response to a pressure gradient between CSF and venous blood. Other sites of CSF absorption include the veins and lymphatics found around the spinal nerve roots and spinal nerves at the intervertebral foramina and associated with the cranial nerves 1, 2, and 8, where they pass through the skull bones. CSF passes through the cribriform lamina of the ethmoid bone, where it is absorbed or leaks into the nasal cavity, resulting in cerebrospinal rhinorrhea. 8. The small amount of CSF in the interstitial spaces of the parenchyma may be absorbed into the parenchymal blood vessels. In reality, CSF is formed and absorbed throughout the ventricles and the subarachnoid space. It is in constant motion and progresses over the surface of the brain and spinal cord, with its rate of production being independent of ICP. Absorption is the primary homeostatic mechanism for the maintenance of the ICP by CSF. No lymphatics exist in the CNS, and CSF provides for some of the lymphatic system functions that occur in other tissues. Fluid compartments. 3 extracellular fluid compartments in the cranial cavity are associated with brain parenchyma. 1. Plasma. 2. CSF, and 3. Extracellular fluid. Exchanges among them are critical to the normal maintenance of brain function. The morphologic and physiologic barriers among these compartments have some unique features. The blood-brain barrier, BBB, exists between plasma and the extracellular fluid of the interstitial spaces at the level of the capillaries. Morphologically, this BBB consists of an unfenestrated, tightly joined layer of endothelial cells of the capillary wall surrounded by a thick basement membrane and a relatively complete layer of foot processes from astrocytes on the surface of the basement membrane. Much of the barrier is dependent on physiologic mechanisms within the endothelial cells. Numerous carrier-mediated transport systems have been defined for this barrier. They may function as bidirectional pathways or primarily for influx, for example, for glucose and large neutral amino acids, or just for efflux to rid the parenchyma of excessive glutamate or glycine and to maintain extracellular potassium at a level that will not interfere with neural transmission. When this barrier is normal, it prevents therapeutic levels of the antibiotic penicillin from entering the parenchyma but allows ready passage of chlorimycidin and sulfonamides to reach antibacterial levels in extracellular fluid. In mammals, the anthelmintic ivermectin is prevented from passage through the BBB by the presence of a P-glycoprotein. It is thought that the breeds of dogs that are susceptible to ivermectin toxicity lack this function of the BBB because of a mutation in the MDR1 gene, which causes defects in the coding for P-glycoprotein, which is important in the adenosine triphosphate, ADP, dependent drug efflux pump. This is most common in collies but also occurs in Australian shepherds and Old English sheepdogs. Like ivermectin, certain chemotherapeutics are also affected by this efflux pump. This is important clinically because administration of this anthelmintic, ivermectin, and certain chemotherapeutics to susceptible dogs may result in severe neurologic signs and death. The blood-CSF barrier exists between plasma and CSF at the choroid plexus and consists of 2 cell layers separated by a thin basement membrane. The vascular endothelial layer and its basement membrane have fenestrations, and the cells lack tight junctions. The choroidal epithelium consists of large cuboidal cells with tight junctions at their ventricular surfaces. Fragments of meningeal cells are interspersed among these endothelial and epithelial cells. See figure 4-1. They serve as a semi-permeable membrane between plasma and CSF. In acid-base imbalances, carbon dioxide readily passes between plasma and CSF, whereas bicarbonate exchange is slow because of the relative impermeability of this barrier to bicarbonate. No significant barrier exists between CSF and the ventricles or the subarachnoid space and the very limited extracellular fluid in the minute interstitial spaces of the adjacent parenchyma. The ependymal cells that line the ventricles are mostly thin squamous cells with incomplete intercellular junctions and no basement membrane between them and the adjacent subependymal cells or neuroglial cells. CSF can move in either direction through this barrier. On the external surface of the CNS, the pia and astrocytic foot process is separated by entire basement membrane form a permeable pyoglial membrane. No intercellular junctions exist in this membrane, which extends into the parenchyma along blood vessels for a short distance, where it defines a perivascular space. Thus, metabolites and CSF have ready access to the extracellular fluid of the parenchyma that is important in maintaining normal brain function. Function CSF serves to protect the CNS through its physical support, with the parenchyma suspended in this fluid medium. It protects the CNS through its role in modulating pressure changes that occur, especially in the closed cranial cavity. In conjunction with cerebral blood flow, CSF helps regulate ICP. It protects the parenchyma by being a source of nourishment because CSF is a medium for the transport of metabolites and nutrients between blood and the CNS parenchyma. It also serves to transport neuroendocrines and neurotransmitters within the parenchyma. CSF plays a role in maintaining the ionic balance necessary for neuronal function by acting as a chemical buffer for the parenchyma. By means of its close relationship to extracellular fluid in the interstitial spaces, CSF provides a more stable and closely controlled ionic environment compared with blood plasma. At necropsy, when studying young animals with extensive leptomeningitis, it is surprising how profound their diffuse neurologic signs are with these lesions confined to the subarachnoid space in the absence of any microscopic parenchymal lesions. Cryptococcal meningitis in dogs and cats and bacterial meningitis in calves are examples of this observation, which reflects the importance of CSF in providing vital nourishment to maintain parenchymal function. Clinical application of cerebrospinal fluid. CSF may be analyzed for its cellular and chemical constituents, antibodies, and infectious agents. CSF is used in neuroradiographic procedures to demonstrate the shape of the CSF containing ventricles or subarachnoid space and to reveal changes caused by disease. Both require the anatomic knowledge and technical skill to access the subarachnoid space. In the dog and the cat, the most reliable source of CSF is at the cerebellomedullary cistern. The cistern at the conus medullaris is too small to be a routinely reliable source. Lumbomyelograms are usually performed at the L5, L6 articulation in the dog and at the L6, L7 articulation in cats. Occasionally, at these lumbar vertebral sites, enough CSF can be obtained prior to the injection of the contrast agent to allow for its evaluation. In the horse, ox, sheep, goat, pig, and camelidae species, both the atlanto-occipital and lumbosacral sites are useful sources to collect CSF for clinical evaluation. Detailed descriptions of the dog and the horse that are applicable to the other species are provided below. Cerebellomedullary cistern. Cerebrospinal fluid collection. CSF collection at the cerebellomedullary cistern in all species requires general anesthesia to ensure restraint of the patient and to eliminate discomfort. The following description for small animals is the same for large animals except for the accommodations necessitated by the differences in sizes. The skin over the occipital bone and first two cervical vertebrae must be surgically prepared. For right-handed individuals, the patient should be placed in left lateral recumbency, with its head and neck positioned level at the edge of the table. Have an assistant elevate the nose slightly so that it is parallel with the vertebral column, and flex the atlanto-occipital joint so that the median axis of the head is approximately at a right angle to the median axis of the neck. Excessive flexion may bend the endotracheal tube and obstruct respiration. Right-handed persons should place the thumb of the left hand on the external occipital protuberance and the first finger of this hand on the cranial aspect of the right wing of the atlas. From these landmarks, an imaginary line is drawn caudally along the dorsal median plane from the external occipital protuberance, and another line is drawn transversely between the cranial edges of the wings of the atlas. The point where these two lines cross is where the needle should be inserted, directed at the angle of the mandible. The needle should be approximately parallel with the ramus of the mandible. To avoid contamination, it is advisable to use sterile surgical gloves. In reality, you cannot palpate the space between the dorsal edge of the foramen magnum and the arch of the atlas, so there is no need to palpate the area where you performed a surgical preparation, and if you handle only the hub of the needle, surgical gloving is not necessary, although it is a worthy precaution. For most dogs and cats, a spinal needle with a stylet that is 1.5 inches long and of 20 or 22 gauge is adequate. A 3.5 inch, 20 or 22 gauge spinal needle may be necessary in some of the larger dog breeds. In the horse and the ox, a 3.5 inch, 18 or 20 gauge spinal needle may be used. Figure 4-12, with the bevel directed to one side. Insert the needle through the skin and underlying fascia and muscle, directing it toward the angle of the mandible. To support the needle for removing the stylet, place the palm of your left hand on the head over the external occipital protuberance for support. Grasp the hub of the needle with the fingers of your left hand and do not move your left hand until the procedure is completed. Remove the stylet with your right hand and observe for fluid. Some practitioners remove the stylet after penetrating the skin and set it aside as that is the most common tissue to plug the needle lumen. You want to know how far to go. It is difficult to describe it here because much difference exists between a Chihuahua and a Great Dane, so use trial and error carefully. We recommend that you initially practice this on a few euthanized, at the hub at 1 mm intervals. Occasionally, you will feel a slight loss of resistance or a slight pop when you penetrate the atlanto-occipital membrane and draw it together and enter the subarachnoid space, but do not count on that feeling. Because the cistern is small in all cats and the small breeds of dogs, holding the needle hub tightly, with the left hand braced on the head, will prevent you from dislodging the needle when you remove the stylet. If you strike bone, you may be able to judge which bone you are on and walk the needle either cranially off the atlas or caudally off the occipital bone before inserting the needle farther. Usually when you are in the cistern, the CSF will immediately appear in the needle hub. Do not advance the needle without the stylet so the tissue will not obstruct the needle. In small patients, such as cats and toy breed dogs, use a 21 gauge butterfly needle because the capillary forces will contribute to the flow of CSF. Usually, CSF pressure is not measured, but if that determination is desired, the manometer and its three-way valve should be attached to the needle hub as soon as CSF appears. The opening pressure may be recorded, a sample of CSF obtained, and the closing pressure recorded by directing the valve accordingly. Recording CSF pressures from the cerebellomedullary cistern was more common before MRI and CT were so readily available. Elevated pressures were considered to be consistent with CNS disease. If desired, a sterile syringe may be used to aspirate 1 to 2 milliliters from the needle hub without attaching the syringe to the needle hub. Attaching the syringe and applying negative pressure may pull the parenchyma toward the tip of the needle and result in iatrogenic damage. If it is difficult to access the cistern, especially in cats or very small dogs in which the space is small, it may be preferable to let CSF drip into a sterile test tube to avoid attaching a syringe and possibly dislodging the needle from the cistern. cistern. About 15 drops of CSF equals 1 milliliter. Applying pressure to both external jugular veins may assist the flow of CSF. Care should be taken not to move the patient when performing compression of the jugular veins. Many large veins exist at the atlanto-occipital site, most of which are extradural. It is common to have whole blood appear in the hub of the needle when one of these veins has been penetrated. If this is an extradural vein, CSF has not been contaminated, and the needle should be removed from the patient, a new needle obtained, and the procedure repeated. On one occasion, after describing this procedure to collect CSF to a class of 80 students, IAD performed a demonstration on an anesthetized beagle dog. After using 6 needles and obtaining whole blood each time, assuring the students that the CSF was still there and not contaminated by blood, clear CSF showed up in the 7th needle. If blood is present in CSF, it may have resulted from injury caused by the needle to a blood vessel in the subarachnoid space of the cistern, or it may be part of the disease process. If it is caused by the procedure, the amount of blood should decrease as more CSF is withdrawn, and the first aliquots with the most blood should be discarded so that the least contaminated CSF is evaluated. If hemorrhage is part of the disease process, the amount in CSF will not change as it is drawn. If any uncertainty about the reason for the blood exists, centrifugation will remove all the blood from the sample, leaving a clear, colorless fluid if the hemorrhage has been caused by the procedure. If the hemorrhage is part of the disease process, centrifugation will remove the erythrocytes that are present, but the supernatant will have a yellow color, xanthochromia, because of the hemoglobin breakdown products of the erythrocytes in the hemorrhage. Small amounts of iatrogenic hemorrhage are common and will not interfere significantly with CSF evaluation. Warning: when you have had some experience performing this procedure and you have a patient in which you are having difficulty obtaining the CSF, do not become aggressive. Stop and make your clinical assessment without the CSF evaluation. If you persist in your attempts to obtain the fluid, most likely you will injure the middle or first cervical spinal cord segment. The needle should never be allowed to penetrate the CNS at this site. This is called pithing and is a technique used to kill an animal. In some patients, the disease process has obliterated the cistern, preventing you from obtaining any CSF. E.g., have a 3 strikes rule. No more than 3 attempts should be made to obtain CSF by one individual. Increased frustration will result only in a misplaced needle. If a second clinician also fails on 3 attempts, abandon the procedure. A common reason for failure is that the disease process has obliterated the cistern, preventing you from obtaining any CSF. Warning: if you suspect an increase in intracranial pressure, for example, an increase secondary to a space-occupying lesion, either do not proceed with the procedure or be very cautious, when you remove the stylet, to immediately attach the syringe so that CSF is not suddenly released under high pressure. This could lead to cerebellar-vermal herniation and an exacerbation of the neurologic signs. As a rule, it is best to delay your collection of CSF until after neuroimaging. This will allow you to know whether an anatomic reason exists to avoid this procedure. Lumbosacral cerebrospinal fluid collection in large animals. A collection of CSF from the subarachnoid space at the lumbosacral articulation that is described for the horse is applicable to all farm animal species. 15. It is important to know which spinal cord segments are present in the vertebral canal at this level because they vary significantly among species. Table 4-1 addresses this subject and includes small animals for the clinical importance of this anatomy. CSF collection in this location in small animals is not reliable. The disparity between the location of the spinal cord segments and the vertebrae occurs when the vertebral column outgrows the spinal cord. The two develop in direct relationship to each other, with the paired spinal nerves growing laterally through the respective intervertebral or lateral vertebral foramina. With growth, as the spinal cord is displaced cranially in the vertebral canal, the spinal nerves grow in length to accommodate this displacement. This growth takes time. Therefore, Table 4-1 refers to adult animals. All of these spinal cord segments are farther caudal in the vertebral canal in young animals. Because of the remarkable variation in the sizes of various dog breeds, some adjustment is necessary in adult animals. As a rule of thumb, in large breeds, the spinal cord segments are adjusted 1 vertebra cranially so that the 3 sacral segments are in the foramen of L4. In small breeds, the spinal cord segments are adjusted 1 vertebra caudally so that the 3 sacral segments are in the foramen of L6. Lumbosacral CSF collection in the horse is best done when the horse is standing and is under light restraint. 15. Only in overtly excited animals is a tranquilizer advised because it tends to cause the horse to stand with most of its weight supported by one pelvic limb, which results in a displacement of the landmarks used for the procedure. For the same reason, this procedure is more difficult in the laterally recumbent horse. The landmarks used to locate the site for needle insertion are often difficult to palpate, and some variation exists between the sexes and among individual animals. The site of skin penetration is within the depressine border laterally by the medial surface of the rim of the tuber sacral, cranially by the caudal edge of the spine of the 6th lumbar vertebra, and quadrantally by the cranial edge of the 2nd sacral vertebra. Figure 4-13. The spine of the 1st sacral vertebra is short and too deep to palpate. When you palpate the lumbar spines, be aware that the spine of L6 is shorter than the spine of L5, and do not mistake this depression dorsal to L6 as the site for skin penetration. Usually you can palpate the tuber sacral. Estimate a transverse line between the cranial edge of these two protuberances. Palpate the caudal ventral portion of the tuber cocci on each side, and estimate a line between these two protuberances. Where the two lines cross, the dorsal median plane should demarcate the area for skin penetration. Prepare this area surgically. Use local anesthesia of the skin at the needle insertion site and incise the skin before insertion of the needle. Use a 6-inch, 18-gauge, thin-walled needle with stylet for adult horses up to about 17 hands tall. Very tall horses may require a special 8 or 9-inch spinal needle. A 3.5-inch, 18 or 20-gauge spinal needle with stylet may be used in ponies and foals up to about 12 hands tall. A right-handed person should stand on the right side of the horse and rest the right wrist on the dorsal median plane of the horse, cranial to the needle insertion site. Holding the needle hub firmly, advance the needle into the axial tissues. Be sure the needle is perpendicular to the dorsum of the horse in both directions. You may need an assistant to stand an appropriate distance behind the horse to help you with the needle position. The depth of penetration to reach the subarachnoid space varies with the size of the horse. It is about 5 inches in a 450 kg horse. Figure 4-14 shows the thickness of tissue that must be penetrated to reach this space. The space between the arches of S1 and L6 L6 is about 1 inch in diameter. If you strike either of these arches, the needle must be removed and the procedure repeated because the site is too deep to allow you to walk the end of the needle to any distance. A slight loss of resistance may occur when the needle penetrates the yellow ligament and enters the epidural space. When the dura arachnoid is penetrated, a slight reaction from the horse, with tail movement, slight pelvic limb flexion, or axial muscle contraction, may be seen. A light application of a restraining twitch may be useful at this time. At this level, advance the needle slowly, remove the stylet, and look for CSF flow at 1 mm intervals. Ideally, you want to remove CSF from the subarachnoid space that is dorsal to the spinal cord. Often you cannot get CSF to flow here, and it is necessary to carefully pass the needle through the caudal-sacral segments and meninges to the floor of the vertebral canal and slowly back the needle up dorsally into the ventral subarachnoid space. See figure 4-14. In adult horses, the 4th and 5th sacral spinal cord segments are located here, and it is expected that the needle will pass through these segments to reach the ventral subarachnoid space. Therefore, the needle insertion should be done carefully. Clinical signs of injury to these segments resulting from this procedure are rare. Compression of the external jugular veins may aid in the flow of CSF in difficult patients. Rotating the needle may also help to free the needle tip from obstruction by meninges or spinal nerve roots. Gentle aspiration using a syringe is also an option. In the ox, it is usually not difficult to palpate the Deborah sign between the spines of L6 and S1. This site is generally where the dorsal median plane intersects a transverse line between the palpable tuber coxae on each side. A 3.5-inch, 20-gauge spinal needle with stylet is adequate for most adult cattle. Only a few caudal segments exist at this site in adults. In this text, we do not describe the methods of evaluating the contents of the CSF or the results of these evaluations. That subject is aptly covered in textbooks on clinical pathology and neurology. A few of our observations follow. Be cautious in your interpretation of the results of CSF examination. They often do not reflect the nervous system disorder that exists. We have studied brains with extensive neoplastic or inflammatory lesions in which CSF was normal. Likewise, we have studied brains that have had minimal evidence of parenchymal inflammation and no obvious meningeal inflammation but in which CSF was profoundly inflammatory. Where did the excessive cells and protein come from? Did we miss the lesion? We cannot answer these questions, but they support our advice to be cautious. Although CSF analysis may be considered a sensitive test, it is not a very specific test. Abnormalities in CSF often occur but rarely provide a definitive diagnosis alone. Despite massive neoplasia with neoplastic cells in the subarachnoid space, the presence of these neoplastic cells in CSF is rare, or we lack the ability to recognize them. Except for Cryptococcus neoformans, it is rare to find infectious agents in the CSF of domestic animals. In granulomatous meningoencephalitis in dogs, CSF may vary from being normal to being profoundly abnormal. The presence of a few neutrophils is rare but does not rule out the diagnosis. Eosinophils may or may not be present in the CSF of cats with CNS Cutteri larval myosis or in small ruminants or Camelidae species with CNS infection with Pyrrhelophystrongylus tenuis. Remember that lumbosacral CSF normally may have more cells and protein than cerebellomedullary cistern CSF. This is especially true for the protein level at the lumbosacral site. Be careful of overinterpreting abnormalities in CSF that is contaminated by blood during the procedure to obtain the CSF. An excellent example of this is the evaluation of lumbosacral CSF in horses for antibodies to Sarcocystis neurona using the Western blot procedure. An experimental study showed that blood contamination that included just 8 red blood cells could be the source of a positive antibody level in the CSF. Fortunately, the presently used indirect fluorescent antibody, IFA, test is highly resistant to blood contamination. It is common to get a small amount of blood when the lumbosacral site is used. Be aware that differences exist in the normal levels reported for the various species of domestic animals, especially the protein levels. Normal CSF protein rarely exceeds 20 mg/dl in cats, 25 to 30 mg/dl in dogs, 40 mg/dl in cattle, and 80 mg/dl in horses. Now that MRI has nearly replaced the use of milligrams in many small animal neurology practices, it is not necessary to place a needle in the subarachnoid space. So many neurologists do not obtain CSF for evaluation as a routine procedure. CSF is evaluated only in patients in which the MRI suggests inflammation, the exception being a cat with possible feline infectious peritonitis, FIP, when the cerebellomedullary cistern may be obliterated by the inflammation or the herniated cerebellum. Myelography at present. Myelography is rarely performed now that MRI is so readily available. For many years, this was an effective and reliable procedure for diagnosing spinal cord lesions, especially those related to intervertebral disc herniations, neoplasms, and other compressive myelopathies. Myelography may be performed by injecting contrast at the cerebellomedullary cistern or at a subarachnoid site between 2 lumbar vertebrae. The choice depends on the location of the anatomic diagnosis or the preference of the neurologist or radiologist. Iohexol, Omnipaque, 240 mg of iodine ml, is the contrast agent used most commonly at either site. A small amount of CSF is removed and replaced by the recommended dose and concentration of the contrast agent for the size of the patient. When injected at the cerebellomedullary cistern, as no epidural space exists, the contrast will enter the subarachnoid space, which will appear radiographically as 2 straight, thin parallel lines on either side of the spinal cord. Whether the patient is in lateral or ventral recumbency, the contrast surrounds the spinal cord, but the lines appear where the agent is most concentrated because of the thickness of the subarachnoid space in that position. On rare occasions, if the end of the needle is partly in the dura, the contrast will be injected into the subarachnoid space, but a portion will enter the dura where it will separate the fragile desmosomal attachments of the arachnoid membrane to the dura, creating a subdural space. See figure 4-3. This is recognized by the irregularity of the contrast lines. It may extend for the entire length of the cervical spinal cord. Lumbomyelograms are performed in the average-sized dog between the L5 and L6 vertebrae, where the conus medullaris is located. This site is chosen to provide an adequately sized subarachnoid space with a minimal amount of spinal cord parenchyma, usually only the caudal segments. Remember the variation in the locations of the spinal cord segments in dogs of different sizes. It is preferable to use the site between L6 and L7 in small dogs and between L4 and L5 in larger dogs. The lumbosacral site is not used because the subarachnoid space there is very small, if it is present at all. After surgical preparation of the injection site, the needle is inserted on the median plane between the palpable lumbovertebral spines. A 1.5 to 3.5 inch, 20 or 22 gauge spinal needle with stylet is used. If CSF is not obtained when the needle first enters the vertebral canal at this site, the needle is advanced to the floor of the vertebral canal and slowly withdrawn to enter the subarachnoid space. You must be cautious because the needle may penetrate the small amount of parenchyma located here to enter the subarachnoid space. It is difficult to keep the end of the needle solely in the subarachnoid space here, and some contrast often enters the epidural space as well as the subarachnoid space. This can be recognized by the irregularity of the radiopaque lines that course along the spinal cord, especially the wavy line that is seen ventral to the spinal cord on the lateral views, the seagull appearance. At the level of the middle of the vertebral body, you may see a small ventral extension of this wavy line where the epidural space extends into the foramen for the basivertebral vein. Pooling of contrast will also occur where the spinal nerves pass through the intervertebral foramina. On lateral radiographs, the intervertebral foramina will appear opaque with epidural contrast. When this epidural contrast is extensive, it may be necessary to repeat the myelography at another time for better interpretation of the lesion. Alternatively, fluoroscopy may be used, or a test radiograph may be made, to ensure that the contrast is located primarily in the subarachnoid space. Occasionally, a seizure will occur in the immediate post-anesthesia period. This is more common in large dogs in which a cisternal myelography is performed. Although a chemically induced meningitis will occur briefly, this should not be a deterrent to utilizing myelography. In T2-weighted MR imaging, CSF appears hyperintense relative to the spinal cord parenchyma, which mimics what is seen on a myelogram. The major deterrent to the use of MRI is the cost, and occasionally the lesion can be better defined with myelography than with MRI, especially in cases of dynamic lesions. If necessary, myelography may be combined with CT. Lesions are classified according to 3 locations. Figure 4-15. 1. Extradural. This means that the lesion is in the epidural space where, if it occupies space, it will displace and compress the spinal cord and its subarachnoid space. Either the contrast will not pass by the lesion at all and may be deflected centrally, or the contrast will be displaced centrally away from the lesion and thin out as it passes by the lesion. Examples of extradural lesions are intervertebral disc protrusions or extrusions, discus spondylitis, primary or metastatic neoplasms of the vertebrae, and epidural hemorrhages or abscesses. Figures 4-16 and 4-17. 2. Intradural extraparenchymal. This means that the lesion is in the subarachnoid space. It may block the flow of contrast in CSF completely, causing the contrast to form a cup-like shape as it attempts to get around and past the lesion. This cup appearance is referred to as a Gulf T sign. The contrast may be able to get past the lesion in the subarachnoid space but will narrow and usually will still show this cup shape. The most common intradural extraparenchymal lesions are neoplasms such as a nerve sheath neoplasm, meningioma, or nephroblastoma. Figures 4-18 and 4-19. 3. Intraparenchymal. This means that the lesion is developing within the parenchyma of the spinal cord. As the segment enlarges, the contrast lines will narrow and be displaced to the periphery of the vertebral canal. The contrast may be completely prevented from continuing past the area of the lesion and will be deflected to the periphery before it stops. Examples of intraparenchymal lesions are primary neuroectodermal neoplasms such as gliomas, metastatic neoplasms, and granulomatous inflammations. Figure 4-20. Another common example of an intraparenchymal lesion is the edema of spinal cord swelling caused by fibrocartilaginous emboli. This lesion can often be identified accurately by the distribution within the spinal cord on transverse MRI sequences and knowledge of the vascular supply to the spinal cord. Intraparenchymal lesions are sometimes difficult to distinguish from intradural extraparenchymal lesions on MRI. Hydrocephalus. Hydrocephalus is described here because it involves the accumulation of excessive amounts of CSF in the brain or the cranial cavity. In fact, the correct definition of hydrocephalus is any increase in the volume of CSF, which means that it is not always related to the cause of any neurologic reference to hydrocephalus, with varying usefulness. Internal hydrocephalus is ventricular dilation with CSF accumulation. External hydrocephalus is CSF accumulation in a dilated subarachnoid space. This is also referred to as hydrocephalus ex vacuo. Non-communicating hydrocephalus is ventricular dilation caused by an interventricular obstruction of CSF flow preventing communication between the ventricular system and the subarachnoid space. Communicating hydrocephalus is ventricular dilation secondary to an extraventricular obstruction of CSF flow or absorption. Normotensive hydrocephalus is associated with normal CSF pressure. Hypertensive hydrocephalus is associated with an increase in CSF pressure. The two major categories of hydrocephalus are compensatory hydrocephalus and obstructive hydrocephalus. Compensatory hydrocephalus and compensatory hydrocephalus. A disease process has caused the loss of parenchyma, and CSF volume has increased. Hydrocephalus, to take up the space previously occupied by the portion of the lost parenchyma. CSF increases in volume to compensate for the loss of parenchyma. The clinical signs relate to the primary disease process that has resulted in the loss of parenchyma. Some examples include in utero viral infections that cause hypoplasia and atrophy of portions of the parenchyma. For example, the cerebellum with bovine virus diarrhea, BVD, infection in calves, and the cerebrum with acobane viral infection in calves, which result in hydranencephaly. Figures 4-21 and 4-22. With the former, CSF accumulation is in the subarachnoid space where the cerebellar tissue is absent. In hydranencephaly, CSF accumulation is usually in the lateral ventricles and is normotensive and communicating because its flow to and through the lateral apertures is not obstructed. Thrombosis or vasospasm of the middle cerebral artery related to a Achater species larval migration will, in time, result in a significant loss of the parenchyma in its area of distribution on the lateral aspect of the cerebral hemisphere. CSF will accumulate in the enlarged subarachnoid space at this site. Figure 4-23. In thiamine-deficient cattle, the resulting cerebrocortical necrosis, polyencephalomalacia, may result in complete loss of the affected neocortex if the animal survives. CSF will accumulate in the widened sulci between the shrunken gyri. Figures 4-24 and 4-25. These are all examples of normotensive communicating compensatory hydrocephalus. Obstructive hydrocephalus obstruction to the flow or the absorption of CSF causes CSF pressure to increase and the ventricular system to expand. As a rule, the lateral ventricles are most susceptible to this expansion, which results in more loss of adjacent cerebral white matter than gray matter. The cerebral cortex is relatively spared. A number of different conditions may cause the obstruction of CSF flow, and CSF pressure varies with the disease process and when it is measured. Obstructive hydrocephalus may be subdivided into acquired forms and developmental forms. Acquired obstructive hydrocephalus neoplasia may interfere with CSF flow through the interventricular foramen, third ventricle, mesencephalic aqueduct, or lateral apertures. This will produce an uncommunicating hypertensive hydrocephalus in the ventricular compartments rostral to the obstruction. Figures 4-26 through 4-28. Most of the clinical signs relate to the effect of the growth of the neoplasm in the involved parenchyma, but the hypertensive hydrocephalus may contribute to these signs. Neoplasia may interfere indirectly with CSF compression of the venous sinuses. CSF volume may not be obviously increased, but its pressure will be increased at the cerebellomedullary cistern. Caudal cranial fossa neoplasms, which interfere with the flow of CSF through the foramen magnum, may cause an expansion of the entire ventricular system, including the fourth ventricle. In addition, a syringihydromelia may occur in the spinal cord, especially in the cervical segments. Inflammations that involve the ependyloma at the narrow components of the CSF flow pathway in the brain may cause obstruction and a hypertensive non-communicating hydrocephalus. The best example of this is FIP in cats. This is the most common inflammation in the CNS of cats, and the virus has a predilection for the ependymal lining of the entire ventricular system, including the choroid plexuses and the central canal in the spinal cord. Mesencephalic aqueductal obstruction is common in this infection and results in expanded third and lateral ventricles. Figures 4-29 and 4-30. When a pathologist examines the transverse sections of the brain of a cat and cannot see the normal small opening of the aqueduct, infection with the FIP virus should be strongly suspected. Bacterial meningoencephalitis in young farm animals may also obstruct the mesencephalic aqueduct, resulting in expanded lateral ventricles. Figures 4-31 and 4-32. CSF flow may be obstructed at the lateral apertures by the choroid plexitis caused by of the same viral and bacterial agents. Periventricular, choroidal, and meningeal suppurative inflammation has been associated with hydrocephalus in 6 to 8-week-old dogs. It was assumed to be of bacterial origin. Some of these lesions may be confused with a traumatic or ischemic lesion that commonly occurs in the white matter adjacent to markedly expanded lateral ventricles in young dogs with developmental obstructive hydrocephalus. This is described later in this chapter. Vitamin A deficiency in calves causes a dural fibrosis that affects the arachnoid villi and interferes with the absorption of CSF, resulting in CSF hypertension. The degree of CSF hypertension directly correlates with the degree of vitamin A deficiency. Minimal hydrocephalus is associated with this deficiency. It occurs most commonly in western North American ranges in 6 to 8-month-old beef cattle kept on dry, vitamin A deficient pastures with no green feed for a number of months. We have also seen an older German shepherd dog that had late onset of seizures and dementia with hydrocephalus that was thought to have been caused by degeneration of the arachnoid villi, similar to that seen in some older humans. Resolution of the clinical signs occurred after placement of a ventriculoperitoneal shunt. Occipital bone hypoplasia that results in a small caudal cranial fossa and herniation of the caudal cerebellar vermis into the foramen magnum often obstruct the flow of CSF through the entire ventricular system, and the obstruction expands to include the fourth ventricle in addition to generating a syringihydromelia in the cervical spinal cord. This can be seen on video 4-1, which shows MRI of CSF circulation in a dog with this abnormality. This ventricular expansion may be responsible for the seizures that occasionally occur in these dogs. Developmental obstructive hydrocephalus. Developmental obstructive hydrocephalus, also known as congenital hydrocephalus, is associated with malformations that interfere with the flow or absorption of CSF. The inheritance of these malformations is poorly understood in domestic animals but has been reported in cattle. Small animal breeds at risk include Chihuahua, Maltese, and Pomeranian dogs. The most common malformation involves a stenosis of the mesencephalic aqueduct, which produces a hypertensive non-communicating hydrocephalus. This is often associated with a malformation of the mesencephalon that consists of the development of a single mound of parenchyma for both rostral colliculi and, rarely, partially fused or incompletely divided caudal colliculi. Figures 4-33 through 4-35. In laboratory rodents, this has been described as being inherited as a recessive gene. These dogs are born with markedly expanded lateral ventricles and a third ventricle that is wider than normal. The cerebral hemispheres are reduced to 1 to 2 millimeters in thickness, with occasional foci in the temporal or occipital lobes of only a pugoglial membrane. These dogs often have a prominent dome-shaped skull with a prominent molar at the frontoparietal suture and sometimes one or more areas of lack of ossification in the thin occipital bone. Occasionally, in a newborn foal or farm animal with the same mesencephalic aqueductal stenosis, the cranial cavity is huge, and large areas of non-ossified membrane make up the cavity area. Lining the inner surface of this cavity area is a thin layer of cerebral mantle covering a huge volume of CSF in the expanded lateral ventricle. Figures 4-36 and 4-37. These animals rarely survive. See figure 4-38 for an example of this in a dog. The same degree of severe expansion of the lateral ventricles and similar prosencephalic clinical signs occur in dogs that have no morphologic abnormalities in the brain at necropsy to explain an obstruction. In addition, these dogs demonstrate normal CSF circulation when NTIM contrast ventriculography is performed. We hypothesize 3 possibilities to explain the severe congenital hydrocephalus in these dogs. 1. At a critical time in the fetal development of the mesencephalic aqueduct, the aqueduct was inadequate to accommodate the flow of CSF produced in the third and lateral ventricles. Studies in mice have shown that the patency of the developing mesencephalic aqueducts is dependent on functional motile cilia on the ependymal cells. With ciliary dyskinesia, inadequate opening of this aqueduct may result in enough obstruction to CSF flow to cause dilation of the third and especially the lateral ventricles. The latter leads to a thinning of the extremely delicate cerebral tissue. With growth, the aqueducts may develop to its normal size, allowing CSF pressure pressures to normalize, but the compromised atrophied cerebrum persists too. Studies in mice implicate immotile ependymal cilia in inadequate CSF flow from the ventricular system through the lateral apertures. In addition, immotile ependymal cilia have been related to an increase in CSF production from the choroid plexus 3. A malformation of the arachnoid villi with a deficiency in the number produced or an abnormality in their structure could prevent normal CSF absorption. A communicating obstructive hydrocephalus would result with expansion of the lateral ventricles. No evidence of any obstructive lesions is seen at necropsy. These arachnoid villi are very difficult to locate and study microscopically, which makes this hypothesis difficult to evaluate. Signalment, history, and clinical signs. Although developmental obstructive hydrocephalus occurs sporadically in all breeds of dogs, a much higher incidence is seen in the toy and brachycephalic breeds, especially the Chihuahua, Pekingese, Pug, Boston Terrier, Yorkshire Terrier, Pomeranian, and English Bulldog breeds. 3. This disorder is uncommon in cats. Despite the presumed fetal genesis of the obstruction, clinical signs may not be evident at birth. Most are observed by 3 months of age, some between 3 and 12 months, and rarely beyond 12 months. Some dogs exhibit no clinical signs despite markedly enlarged lateral ventricles with significant cerebral atrophy. This suggests that the clinical signs may be related to the level of CSF pressure, which may be quite variable in these dogs. The most common clinical signs observed are prosencephalic in origin because of the severe expansion of the lateral ventricles, with compromise of the cerebral tissue and compression of the diencephalon. The following description of prosencephalic signs is introduced here but applies to any prosencephalic disorder. Prosencephalic signs, seizures and abnormal behavior will have been observed by the owner but commonly are not observed by you during your examination. Mild changes in the animal's behavior may be appreciated only by the owner who can recognize such changes. They include loss of trained habits, abnormal behavior, lack of recognition by the animal of its environment, and changes in attitude toward the owner. Some of these dogs cannot be housebroken, unlike their litter mates. Progressive loss of the animal's sensorium or its level of consciousness or response to the owner or you is described with the following terms: depression, lethargy, obtundation, semi-coma, stupor, and coma. The last two usually implicate significant involvement of the ascending reticular activating system in the diencephalon. The anatomy of this system is described in Chapter 19. The owner is better able to recognize a mild change in attitude to more docile or more aggressive behavior. The latter may include hysterical or maniacal behavior, which also will be obvious to you. Head and neck turning to one side, pleurothonus, and propulsive pacing and circling are commonly associated with frontoparietal lobe or ostrothalamic disorders. Usually, but not always, the patient tends to turn or circle toward the side on which the lesion exists, which is the basis for the term aversive to turn to syndrome. Seizures or behavioral changes may be the only clinical signs present in a prosencephalic disorder, and your neurologic examination may be normal. In your neurologic examination of the patient, only 3 responses that are tested may be abnormal in the presence of prosencephalic disorders. The specific anatomic aspects of these tests are described in later chapters. If the lesion is confined to the prosencephalon, without enough pressure on the caudal brainstem or cerebellum to result in clinical signs, the gait is normal on a level surface, but postural reactions, of which the hopping response is the most reliable, are mildly abnormal. Visual perception tested by the menis response is depressed or absent, with no abnormality in the size of the pupils or their reaction to a bright light. Nociception tested on the surface of the body is depressed, especially when evaluated on the mucosa of the nasal septum because of its reliable sensitivity. With unilateral prosencephalic lesions, all 3 of these responses, hopping, menis, nasal septal nociception, are abnormal on the side of the body contralateral to the prosencephalic disorder. Dogs with developmental obstructive hydrocephalus must commonly exhibit change in behavior or loss of sensorium. Loss of vision is common because of the compromise of the optic radiation in the centrum semiovalia and the occipital cortex. Gait is usually unaffected on a level surface. Postural reactions and nociception may or may not be depressed. If ICP is significantly elevated, pressure may be exerted on the brainstem, which will cause a spastic paresis and general proprioceptive ataxia in the gait. The ataxia may also have a cerebellar or vestibular quality, especially if the fourth ventricle has been expanded by the increase in CSF volume. Syringohydromelia may also occur in these dogs and contributes to the gait abnormality. It may also cause excessive neck scratching, episodes of neck pain, and crying out, as well as a cervical vertebral scoliosis. The frequency of syringohydromelia with obstructive hydrocephalus is unknown because it has not been consistently looked for during necropsy or imaging procedures. In all dogs in which MRI reveals an obstructive form of hydrocephalus, imaging of the cervical spinal cord should be considered, depending on the clinical signs and severity of the neurologic dysfunction. In addition to neurologic signs, the cranial cavities may be so enlarged that the skulls of these dogs may have a dome shape and a palpable molar may be present. Remember that many toy breeds, especially the Chihuahua, normally have small molars as adults. Some dogs with enlarged cranial cavities have orbits with abnormal shapes, causing the eyes in some head positions to deviate ventrally and slightly laterally. Sunset eyes. We believe that this strabismus is not caused by compression of the oculomotor nerves on the floor of the cranial cavity because the strabismus is not always apparent in an affected patient and on moving the head repeatedly from one side to the other to test for normal physiologic nystagmus. Each eye adducts well, indicating normal oculomotor nerve innervation of the medial rectus muscles. In addition, the pupillary size and response to light are normal. The following 4 videos of dogs demonstrate the clinical signs of developmental obstructive hydrocephalus. 1. Video 4-2 shows a 7-week-old case one that was lethargic and blind. Note the enlarged cranium, the strabismus, and the retained ability to walk. 2. Video 4-3 shows a 7-week-old beagle, in which blindness was the only complaint. Note the enlarged cranium and the strabismus. At necropsy, this beagle in the case 1 and video 4-2 both had mesencephalic aqueductal stenosis, with extremely enlarged lateral ventricles and cerebral atrophy. Despite the severe prosencephalic compromise, note that these 2 dogs have normal gaits. 3. Video 4-4 shows a 9-week-old Labrador Retriever that was lethargic and blind and had mild vestibular ataxia and a tendency to circle to its right side. Postural reactions were slow bilaterally. The vestibular ataxia was presumed to be caused by the pressure of the enlarged cerebrum on the caudal brainstem. The cranium is not noticeably enlarged. 4. Video 4-5 shows a 4-month-old pug dog with propulsive circling to the right and a normal gait, but poor postural reactions in the left limbs and a poor left side menace response. These clinical signs suggest that the lesion was worse in the right cerebral hemisphere. The cranium was enlarged and had a large frontoparietal molara. CT showed extensive cerebral lesions and a small diencephalon. Note the loss of parenchyma ventrally on the right side and the rostral sections at the level of the head and body of the caudate nucleus. The bone window CT at the end shows the large molara. At necropsy, no obstruction was found, but, associated with the extremely dilated lateral ventricles, tears in the cerebral white matter, especially in the right cerebrum, were seen. The presumed diagnosis was obstructive hydrocephalus caused by an arachnoid villi abnormality. Figures 4-39 through 4-43 show the features of this dog's cavaria and brain at necropsy. Occasionally, sudden exacerbations of clinical signs occur in these dogs and are sometimes associated with an expression of considerable discomfort by the patient. We believe this may be a result of episodes of bleeding into the expanded ventricle. The discomfort may occur because this blood gets access to the subarachnoid space. At necropsy, it is common to see a mild yellow discoloration of either side of the atrophic cerebrum and occasionally blood clots on the wall or in the lumen of the lateral ventricle. These findings are associated with tears in the thin layer of white matter in the atrophic cerebral hemisphere. The most common sites of these tears extend from the lateral surface of the distended lateral ventricle ventrally, lateral to the caudate nucleus. See figures 4-42 and 4-43. This tear is primarily in the internal capsule but may extend medially into the caudate nucleus or laterally into the lentiform nucleus. On microscopic examination of these areas of tissue disruptions, foci of ischemic necrosis and scattered inflammation include macrophages and neutrophils. We believe that the latter reflect recent acute tissue injury, not an infectious process as indicated in some of the literature. The constant stretching of the thin wall of the cerebrum may lead to ischemia and susceptibility to tearing as the result of mild trauma that would not ordinarily result in injury to a normal patient. MRI may reveal this lesion in the ventral internal capsule, where it separates the lentiform nucleus from the caudate nucleus. Another possible cause of episodic discomfort is the development of a cervical syringohydromelia in these dogs. Differential diagnosis: the disorder that is most common at this age and that causes similar prosencephalic signs is hepatic encephalopathy associated with portosystemic shunts. A major difference is that dogs with liver disorder usually have episodic signs related to the quality of the diet and the feeding times. Infectious diseases and inherited storage diseases are other considerations. Diagnosis: numerous ancillary procedures may be used to confirm the diagnosis of enlarged lateral ventricles. Both CT and MRI readily demonstrate such lesions. Figures 4-44 through 4-48. MRI is the most accurate means of defining all components of the intracranial CSF compartments, and it also allows the clinician to evaluate the spinal cord for syringohydromelia. Ultrasonography may be used for a probing through a molar or even the cavaria, if it is thin enough. As in a puppy, a lateral radiograph may show loss of the cerebral gyral pattern, a diffuse homogeneous ground glass appearance, where the lateral ventricle is enlarged and filled with CSF, and a flattened appearance of the cribriform lamina. Before CT and MRI were available, this diagnosis was confirmed by injecting air contrast into the lateral ventricle. The site of injection is on the dorsal aspect of the cavaria, 3 to 5 mm to one side of the median plane and at a transverse level that is 1/2 the distance from the lateral angle of the eye to the external occipital protuberance. At that site, a hole is made in the cavaria by rotating the spinal needle if the bone is thin or rotating an intramedullary pin held in an orthopedic handle. A spinal needle with a stylet is slowly inserted through this opening in bone and into the parenchyma until CSF appears in the needle hub, with severe enlargement of the lateral ventricle. This will occur within 2 to 3 mm from the bone opening. It is often difficult to place the end of the needle in the thin slit of a normal lateral ventricle. To be safe, do not pass the needle into the brain more than 1/2 the height of the cranial cavity, as measured on the lateral radiograph. For a diagnosis, remove a few milliliters of CSF and replace it with a similar volume of air. In this pneumoventriculogram, the radiolucency of the air dorsal to the more radiopaque CSF is obvious in a lateral radiograph. Figure 4-49. If progressive radiographs are made, with the head rotated in different positions, the entire lateral ventricle can be defined by the position of the air. To diagnose the location of the obstruction that caused the ventricular expansion, a radiopaque contrast agent is injected to replace the CSF that was removed. Within a short time, a lateral radiograph of a normal animal will show the contrast in all of the brain ventricles and in the subarachnoid space intracranially and around the spinal cord. Contrast ventriculography confirms that CSF can circulate through the ventricles and exit through the lateral aperturus. If the mesencephalic aqueduct is stenotic, figure 4-50, no contrast will be evident in the fourth ventricle or subarachnoid space. Figure 4-51. If the lateral apertures are inadequate, contrast fills the expanded fourth ventricle and is not present in the subarachnoid space. If the obstruction is at the level of the arachnoid villi, the distribution of contrast is similar to that of a normal animal except for the expanded lateral ventricles. Warning: be careful in cases of severe hydrocephalus that you remove only a very small amount of CSF before you inject air contrast so as to avoid the collapse of the thin, atrophied cerebrum. In dogs with expanded lateral ventricles and atrophic cerebral mantles, electroencephalography, EEG, typically shows slow wave patterns with markedly increased amplitude in all leads. 6-14 Now that advanced imaging is readily available for diagnosis, it is not necessary to consider injecting air contrast into the ventricles or obtaining an EEG treatment if severe developmental obstructive hydrocephalus is diagnosed in a recently purchased puppy that has debilitating neurologic signs. We believe that euthanasia is advisable because of the poor life expectancy of the puppy. Even with treatment, this advice should be given before the owners and their children become too attached to the puppy. Although low levels of corticosteroids may decrease the rate of production of CSF, the most effective treatment is surgical. A specialized catheter, ventriculoperitoneal shunt, may readily be placed in the lateral ventricle and tunneled subcutaneously to the abdomen, where it is inserted into the peritoneal cavity. The surgical outcome is usually good but is not a cure for all cases, and it requires lifelong maintenance of the shunt. We usually recommend returning the affected puppy to the breeder in such cases.